Есть. Девятое. Пожалуйста.
Welcome to the first lecture on high nervous activity conditioned reflexes. So even though you used to have this topic already before, but still it has to be given to you, the material, so that you can revise in case if you need to. So the objectives which we're going to talk today will be: we will define high nervous activity and behavior. We will discuss physiological basis of behavior. We will talk about acquired forms of behavior and why is it important to learn this topic. Then we will talk about the differences between conditioned and unconditioned reflexes. Also, we will take a look at few classifications of conditioned and unconditioned reflexes, and we will define the dynamic stereotype. We will look at the stages and rules which you need to follow if you want to develop the conditioned reflex. And we will discuss the role of dominance in conditioned reflexes. Also, we will discuss the mechanisms of conditioned reflex formation, that is the temporary connection. And the last but not least, we will talk about inhibition of conditioned reflexes, which types do we have, and some examples will be also given. So, the first question about high nervous activity. So, as you can see, the definition which is given by Pavlov, high nervous activity is the activity of the highest centers within the CNS of animals and humans, which will ensure the normal and complex relations between the entire organism and external environment, which means it provides adaptation. As opposed to the activity of the central nervous system in integrating different parts of the organism, which is called the lower nervous activity. So lower nervous activity, it basically controls the functions of the visceral organs within the organism. And according to Pavlov, high nervous activity, it includes all forms of psychic activity like thoughts, consciousness. They are the components of the high nervous activity. And high nervous activity of humans and animals will be based on conditioned reflexes. And for conditioned reflexes, cerebral cortex is required. And examples of unconditioned reflexes, which some of them you can see here, they are the instincts, for example. They do not really need the cerebral cortex activity. So let's take a look at the comparison between conditioned and unconditioned reflexes. As you can see here, conditioned reflexes, they must be acquired throughout the experience, throughout your lifetime. They are not inborn, unlike unconditioned reflexes. Those are inborn and unlearned, and they are innate. Conditioned reflexes, as you can see, they are not permanent, which means they can disappear throughout the lifetime and then they can reappear back if you want to train them back again. While unconditioned reflexes, they are usually permanent reflexes, which means you have them throughout the lifetime. For conditioned reflexes, you will need cortical centers mostly, while unconditioned reflexes, usually centers will be subcortical. In case of conditioned reflexes, it could be any stimuli. You can use various stimulations, like within the wide range of different receptors. While for unconditioned reflexes, you must use adequate stimulus for definite receptors. Now, for conditioned reflexes, as they're learned and they depend on your personal experience, they will vary considerably from species to species, and even within the same species, like me and you, we might have some different conditioned reflexes. while unconditioned reflex, they're found virtually in all members of the same species, which means they're same for all humans. And as such, conditioned reflexes, they will vary from individual to individual. Unconditioned, they almost do not vary, they are stable. And one of the most common examples of conditioned reflex will be salivating to light bulb. This is like the classical conditioning, which was given by Pavlov. And unconditioned reflex, salivatory reflex, when the food is taken into the mouth, or some of the reflexes which you used to do during the class time. So whenever we talk about conditioned reflexes, we think about Ivan Pavlov. And I guess that name rings a bell in your mind. This is basically the scheme of how he did his experiments. You can see there will be a dog kept within the room, and there will be food given. Also somewhere here there will be a stimuli, which is a light or a bell, and as you can see there will be a device collecting the saliva and measuring exactly the amount of saliva which the dog is producing related to the time frame. So how conditioned reflexes are used nowadays, and why is it important to still learn them? This is about Pavlov's impact on nowadays activities. As you can see, Pavlov's conditioning, these techniques, doctors, they are using to desensitize humans, and also you can do that in animal patients as well, to make them get used to some painful procedures and to get rid of some phobias, like for example visiting a dentist. Another impact of Pavlov's conditioning is that scientists applied Pavlov's ideas about learning to other animals, from insects to mammals. So basically it works not only in dogs, but it works virtually in all species. And even though he did lots of experiments on dogs, but he was following ethical standards. And actually he was one of the first who introduced these ethical principles for animal experiments. And even though Pavlov, he was a physiologist on first hand, but his ideas, they directly influenced the behavior theories in psychology. So conditioned reflexes, they're also called classical conditioning, and they're also known as Pavlovian or respondent conditioning. This is when animal or human will be acquiring a new response that will be called a conditioned response to a previously neutral stimulus or the conditioned stimulus. That will actually give a signal that there will be arrival of unconditioned stimulus. So let's take a look on how does this happen. Classical conditioning, this is a type of learning where neutral stimulus comes and it will bring about the response as soon as it will be paired with the stimulus that naturally brings that response. So what does that mean? We have neutral stimuli, a stimuli which does not produce any particular response, like a bell, ringing a bell, or switching the light, which means nothing. And here you should use unconditioned stimulus, a stimulus that naturally brings about a particular response without having been learned. So basically that's what you have for unconditioned reflex. And unconditioned response, the response which naturally follows. So that's the natural reaction of the organism, and that's what we have for unconditioned reflex. And as soon as the combination of a previously neutral stimulus will be paired with this, eventually human or animal will learn this association, and previously neutral stimulus will turn into conditioned one. Once neutral stimulus that was previously paired with unconditioned stimulus, and unconditioned response was produced, it will bring about conditioned response, a response which happens after conditioning. So, what could be used as unconditioned stimulus? In Pavlov's experiment, unconditioned stimulus, that was the food. Usually he was using meat. And as you understand, it produces very specific response, which is salivation. So whenever the food is placed into the dog's mouth, there will be salivation, which is unconditioned response. This is natural, it happens in all dogs. Now, what about conditioned stimulus? Conditioned stimulus, that's the stimulus which was previously neutral. But since you repeated this association with unconditioned stimulus and response for a couple of times, there will be association which will produce conditioned response and conditioned reflex. For example, if you're gonna use the bell paired with food for a couple of times, eventually, even if no food is given, ringing a bell alone will produce salivation. So this is what is called classical conditioning. And here, previously neutral stimuli becomes conditioned stimuli, producing conditioned response. Here you have few classifications of conditioned reflexes. They could be used, they could be classified based on the methods. They could be natural, unnatural, or artificial. Based on the receptors, could be extero, proprio, interoceptive. They could be classified based on the final result or the system which is involved, like motor, visceral, cardiac, secretory, and so on. According to the time period, when will they happen, like classic, trace, delayed. They could be also simple and complex, classical and instrumental. According to biological importance, nutritive, sexual, defensive. According to the order, means how many conditioned stimuli you might use, first, second, third order, and so on. Based on the sensory modality, whenever you're using sound, light, temperature, or any other stimuli, and according to the reaction, positive activation or negative inhibition. So if a salivation happens, it's positive. If salivation is inhibited, then means it's negative. Now, one of the examples of classical conditioning will be dynamic stereotype. Dynamic stereotype, that's a fixed stereotype succession of conditioned reflexes. What does that mean? Which means when you're repeating the same routine day by day, which consists of like few actions, eventually this routine will become your conditioned reflex or dynamic stereotype. And once this stereotype is established, it becomes an automatic and inert. So you don't have to focus it. The entire sequence goes by itself. As an example, you can use your morning routines when you wake up, when you comb your hair, when you get ready for classes. So all that succession of movements, it could be called dynamic stereotype if you're repeating that number of activities the same way throughout the day. And it's very useful since it makes your brain cortex free to focus on something else. Now, back to the classical conditioning. So basically, this is the scheme of how classical conditioning happens. You can see before conditioning, we have neutral stimuli, which is the bell, which cause no reaction. In our case, there is no salivation because that's just a bell. But if you will pair this neutral stimulus with unconditioned stimulus, which is the food, and the food obviously gives the salivation. After you will repeat this combination for a couple of times, then you can remove the food and the bell alone will produce salivation. So let's talk about rules and stages of conditioned reflexes and the mechanism of conditioned reflex. So there are a few rules or laws of conditioned reflexes which you need to follow. As you know now, you will need two stimuli. One should be unconditioned stimuli, the one which is associated with a particular response, that's the food. Another one is neutral stimuli, which will become the conditioned stimuli. There must be a motivation for unconditioned stimuli, which means if you're going to take the food, the dog must be hungry, because if the dog is not hungry, nothing is going to happen. Then your neutral stimuli, it has to be strong enough, which means if the sound of the bell will be barely heard, the dog might not react to it and might not create the association. Then conditioned stimuli, it must be neutral or indifferent, which means by itself it shouldn't produce any particular response, and it has to be neither too strong nor too weak, because for example, if you're gonna use too loud sound, the dog might get scared, and here you will have defensive reflex, and obviously there will be no conditioned reflex developed in this case. Now these neutral stimuli which you have chosen, it has to be supported by unconditioned stimuli, which means you're going to use the bell, for example, and then you're going to give the food, but bell comes first. And these combinations should be repeated. You cannot develop conditioned reflex from one single try. The environment should be quiet, means there should be no other stimuli, no other distraction of the animal. And of course, the subject must be healthy and alert, means not sleeping, not bothered by any kind of pain or any other disorders. So these are the basic rules if you want to develop conditioned reflex. So here you can see the scheme of how conditioned reflex could be developed. You can see this is our conditioned or neutral stimuli, like ringing a bell. As you can see, after ringing a bell, no saliva is produced. But as soon as you're giving the food, which is unconditioned stimuli, immediately the dog sees the food, saliva will be produced. And that's a normal reaction. And after you will combine these stimuli in such a way for a couple of times, you can see that salivation will happen slightly before even the food is given. So, which means the conditioned stimuli, which for example could be the bell, by itself already will be associated with the upcoming food. And if you will succeed, you can see giving the conditioned stimuli will bring about the response. So at this stage, you can already remove the food, and bell alone, sound of the bell, will give you salivation. So how the conditioned reflex will be produced? The production is based on temporary connection. So on the first diagram, you can see the scheme of unconditioned salivatory reflex. How does it work? Whenever the food is placed into the mouth, taste receptors will get activated, and the stimuli will be sent to salivary center, which is in the medulla, and then back to the salivary gland, so that saliva will be produced. But at the same time, whenever you take food into your mouth, impulses will be also sent to the cortical digestive center, because of course you are consciously aware about the type of food you have taken, temperature, consistency, taste, and all other characteristics of the food. And that happens due to the brain cortex. Now, this is what you have, and this is the unconditioned reflex. Food into the mouth, salivation occurs. But if you want to get the conditioned reflex, for example, you're going to ring the bell, and stimuli will eventually reach the cortical hearing center. After that, you're going to give the food, which will activate the salivation. And after this combination will be repeated a couple of times, impulses from the cortical hearing center will be traveling to the cortical digestive center, and temporary connection will be produced between these two cortical centers, creating the association between ringing the bell and salivation. So why does it happen? Like, why the bell, which doesn't mean the food, but through the repetition of this combination, will be associated with a particular type of food? This is because of the dominant principles. Dominant means to prevail, and in terms of the CNS, that's the foci of the excitation which is prevailing within the CNS, and it will change and subordinate the activity of all the other centers. What does that mean? In case of food which you are trying to use as unconditioned stimuli, the dog must be hungry. And even if you will think about yourself, whenever you're hungry, you cannot think about anything else. Your dominance is to go and get some food. Hunger, that's what motivates you. So in this case, there will be hunger center dominating over all the other centers. And the properties of the dominant, it's highly excitable, the excitation is stable, and it suppresses the functions of all other centers and attract the excitation from them. And this is exactly what happens. There is a hunger sensation, and since you're gonna give some stimuli, this dominant center will attract all the other stimuli towards itself based on the dominant principle. And whenever you are trying to develop a conditioned reflex, there will be two stages: generalization and discrimination or specialization. Generalization means whenever you are giving two stimuli which are similar in nature, means, for example, you are giving two sounds which are quite similar but not exactly the same, but only one sound is supported by the food. For the first couple of times, the dog will be producing the saliva for both of them, but eventually the dog will learn how to differentiate which sounds does mean the food and which sound is not going to bring about the food. This is the discrimination. Only the sound which was previously supported will give saliva, and all similar sounds will not produce the saliva. And the last question from the higher nervous activity will be about inhibition of conditioned reflexes. So here you have a small summary. There are two types of inhibition. One is external and one is internal. External, the other name is unconditional, and internal, the other name is conditional. External meaning that the inhibiting factor, it lies, the reason for inhibition, it lies outside the reflex arc of your conditioned reflex. Internal, the reason is within your reflex arc. So for the external or unconditioned inhibition, the example you have transmarginal inhibition. Transmarginal means beyond the limits. What does that mean? If intensity of the conditioned stimuli exceeds a certain limit, the result will not give you the reflex. In fact, it will be weakened or it might be totally inhibited. For example, if the sound which you're gonna give will be too loud, or for example, if you're gonna ring the bell and give the food to produce salivation, but if at the same time you will place a cat next to the dog, obviously there will be no salivation, because the cat quite close to the dog, this is something beyond the limits, something which the dog cannot stand. And as you can see, you didn't change the procedure much, but introducing a new factor into it changes the whole thing. This is transmarginal or beyond the limits. Internal conditioning, internal inhibition. This is when you're changing the procedure itself. For example, the first type of inhibition is extinction. This is when you will stop reinforcing the conditioned stimuli. Let's say you gave a bell a couple of times, but you were not giving the food next to it. And eventually the dog might forget that this particular sound means food, and reflex might fade away. What's the use of it? Maybe the reflex is no longer important and it makes sense to inhibit it for a certain period of time. Quite similar to it will be the delayed inhibition. This is when the time taken between the bell or conditioned stimuli and your reinforcement, it's too long. The optimal one, it should be like within 1 or 2 minutes. The shorter, the better. But if you will give the food way after the stimulus, the dog might not have that association that the food or the bell actually means the food, and there will be inhibition. And two more examples, is the differential and conditioned inhibitor. Differential, this is what happens at the stage of generalization followed by differentiation or specialization. There are two stimuli which are alike, but only one is supported by unconditioned stimulus. At the first phase, as you remember, the animal will be reacting to both since they are pretty much the same. But after some time, the dog will learn how to differentiate, and the other stimuli, which is not supported, will not bring you the response. And the last one, conditioned inhibitor. This is when you have the procedure like bell, food, saliva, bell, saliva. But you're gonna add another stimuli, like for example, you're gonna use exactly the same bell, but paired with the light, for example. And for the dog, it will be totally new combination, which is not previously associated with the food, which means the dog might not produce the saliva and your conditioned reflex will be inhibited. So that's all as for the higher nervous activity and conditioned reflexes. And now I'm going to describe, answer on few questions which you have given upon request. So the first one, which I'm going to talk about, we will briefly revise the gastrointestinal motility. So we will go through the compartments, and we will talk about, like, there will be a division of GI tract, then we will list the types of motility which are present, and we will briefly outline the regulation of motility. So what do we have? In mouth, you have two types of motility, which is the mastication, motor function, and swallowing. Mastication or chewing is needed to lubricate the food, to mix it with saliva, and to decrease the size. So basically, that's the food grinding. You are making the food particles smaller, which will make the swallowing easier, and that's basically enhances the digestion. And talking about mastication, there are 5 phases. The first one is the resting phase, when nothing happens. Then entering of food into the mouth, that's when you place it into the mouth. Then there will be orientation phase. This is when you make a few movements trying to realize what kind of food you have taken. Then the longest one is the basic phase, which is the chewing. And the last one is the formation of bolus. And then there will be a swallowing. For the regulation, chewing or mastication, it's under both conditioned and unconditioned. Most of the time, mastication happens without focusing on it, just because of the center which is localized in the medulla. But we still have chewing center in the brain cortex, and you can voluntarily modify the way you chew the food. But most of the time, it's unconditioned reflex. Another example of motor activity is the swallowing. Swallowing consists of 3 phases. First one is the oral phase, which is voluntary, which means you may swallow, you might not. Pharyngeal, that's already involuntary, that's the rapid involuntary. And esophageal, that's slow involuntary phase. One of the most important out of three is the pharyngeal phase, because in this phase, it's really very important for the bolus to go into the esophagus, even though there are a couple of other openings the food might enter. But it will not, because the nasopharynx will close, and at the same time the breathing is inhibited, and also the glottis will close the openings of the larynx, and it will be also elevated a little bit. And that's the reason why you should never talk while eating, because you can choke. Regulation, as you can see here, it will be involuntary. There will be afferent and efferent nerves, and the deglutition center is in the medulla. Now, the next one is the stomach. And here you can see we have few physiological types of motility. You have hunger contractions or fasting contractions. This is when there is no food in the stomach. And this is what is related to the empty stomach hunger theory. When you will start eating, the first thing which is going to happen is the receptive relaxation. This is due to the vagovagal reflex, and receptive relaxation is needed so that the stomach can accumulate more food. Whenever stomach is empty or full, there will be tonic contractions. There is a tonus in the walls of the stomach. Then, when there is a food kept in the stomach, there will be peristalsis. Peristalsis and stomach you need for both, for mixing of the food and to propel it in caudal direction. And as a subtype, you have antral systole contractions of the antral part for the gastric emptying. And sometimes you can see that in stomach, there might be pathological type of contraction, which is antiperistalsis, and it leads to vomiting, but it's not normal. Now, mechanisms of regulation, they will be same as everywhere else. You have neural and you have humoral. For the neural, you have central and you have local. For the central, you have parasympathetic and sympathetic nervous system. Parasympathetic through the vagus, it increases the gastric motility. Sympathetic through the nerves coming from thoracic segments, it will inhibit the gastric motility. And in stomach, we also have local or enteric nervous system, which increase the gastric motility. As for the humoral control, we have gastrin, and the strongest and the most influential is the motilin. They will increase motility. And hormones which are produced by the intestine, they will decrease the motility. So this is as for the stomach. Now, talking about the duodenum or the gallbladder. As you know, the bile is produced in the liver, then it's kept and stored in the gallbladder, and whenever it's needed, it will be released into the duodenum. To release the bile into the duodenum, you need to contract the walls of the gallbladder, and you need to relax the sphincter. So under the motility for the gallbladder, you have contractions of the gallbladder and contraction or relaxation of the sphincters. Here you have OD sphincter. Regulation will be same, nervous and humoral. Under nervous, you have parasympathetic, which will cause contractions of the wall and relaxation of the sphincter. Sympathetic does the opposite. For the humoral control, the most powerful substance which increases the force of contractions and relaxes the sphincter is the CCK, which is cholecystokinin. Now, talking about intestine, small and large. In small and large, contractions could be divided into two types, propulsive and mixing. Propulsive means they are propelling the food in towards the rectum. So here will be the peristalsis. For mixing, you have two types, pendulum movements and rhythmical segmentation. This is when the chyme which is present in the intestine will be mixed with the juices for better reabsorption and the final stages of digestion. here, of course, you also have tonic contractions, and in small intestine, you also have contractions of microvilli to facilitate absorption. And as a pathological type, you have antiperistalsis. And for the control, here it's the same way. You have local and central. And as you can see, local already here comes on first place, because in small and large intestine, that's the most important mechanism of regulation. So enteric nervous system, it increases the motility in both small and large. Then for the central, we have parasympathetic and sympathetic. Parasympathetic vagus increases motility, sympathetic decreases motility. Now, for the humoral control, here you have few hormones which will either increase motility or decrease. In large intestine, it will be pretty much the same, but instead of peristalsis, you will have a mass peristalsis. And in case of mixing, you can see here antiperistalsis becomes normal, but still the content of the large intestine will not enter back the small, because you have the sphincter separating these two. And instead of rhythmical segmentation, because of the structure of the large intestine, you will have haustrations. Also, you have tonic contractions, and the final one will be dedification to remove the wastes. Now, one more thing, as for the bile secretion, in your books, all the substances which are related to the bile, they're divided into 3 categories. Choleretics, substances which will increase secretion. Then cholagogues, those which increase the discharge of the bile. And the last group, substances which cause secretion of bile from the liver with large amount of water. And here you can see the examples of substances with such effects, because sometimes you might separately would like to increase the amount of bile, or you would like to increase the discharge of bile from the gallbladder. Now, a few more things about the gastric emptying. Gastric emptying doesn't happen like all of the stomach content into the duodenum. No, it happens bits by bits, so it's partial. And there will be few factors which might influence the way it gets empty. First one is the volume. If the food volume in stomach increases, it promotes emptying, which makes sense. You have to empty it faster, because antral distension will stimulate vagovagal reflex, leading to increased antral pump activity, and sphincter will get open, the pyloric sphincter. Now, liquid versus solid food. Liquid type of food leaves the stomach way faster compared to the solid foods. And type of the food also matters. As you can see here, the longest it takes for the fats to leave the stomach. So in fact, you can say that fat will inhibit the gastric emptying. And you can see also the rate of emptying depends on tonicity of the stomach content. If it's isotonic, that's the most optimal one. If it's either hypotonic or hypertonic, the emptying will get slowed, as well as pH. If it will be too acidic, receptors in the duodenum will be stimulated and emptying will be slowed down, because it takes for the duodenum longer time to perceive that chyme. And here you can see those two substances, two hormones, which we have previously mentioned for the gastric motility, motilin and gastrin. The most important one is the motilin. And for neural, parasympathetic, and local myenteric reflex, they stimulate the motility. Here you can see the sequence of events for the gastric emptying. As you can see, when chyme reaches the pyloric part, distension happens. And besides distension and stimulation of mechanoreceptors, here there will be stimulation of chemoreceptors, since the pH in the pyloric antral region is not as acidic. When these two factors will come a wave of peristalsis or antral systole will be initiated, sphincter gets opened, and the first portion of chyme enters the duodenum. Immediately after it enters, there will be enterogastric reflex, which will close the sphincter. And the sphincter will remain closed until the food which entered the duodenum will be proceeded any further. When duodenum becomes back empty again, the whole cycle will be repeated all over. So, mechanism of gastric emptying at a glance, you can see chyme moves into the pyloric region. It will stimulate chemo and mechanoreceptors, initiating the reflex, which will open the pyloric sphincter plus antral systole. The chyme will be entering the duodenum. Now there will be distension of duodenum bulb, stimulating of chemo and mechanoreceptors, but now of the duodenum, which will cause enterogastric reflex. Pyloric sphincter is closed, and these will ensure that emptying of stomach happens in small quantities. Now, what can inhibit gastric emptying? Or when it happens at a slower rate? Duodenal distension, because if duodenum is distended, which means the chyme is still there, you cannot add new portion of chyme into it. As we already mentioned, osmolarity of chyme, the type of food, acidity, if it's too acidic, and also the temperature. And hormones which might influence, they are the CCK, secretin, and a couple of other hormones produced by the intestines. They are inhibitory. And the sympathetic nervous system also inhibits. Now, a few more words about defecation reflex. Defecation reflex, it will be under both voluntary and involuntary control. What does that mean? Whenever feces, they reach the rectum, distension happens of the rectum walls, and mechanoreceptors, baroreceptors will get activated, and through the sensory nerves, impulses will be sent to the spinal cord. Defecation center is within the sacral segments of the spinal cord, which belongs to the parasympathetic nervous system. And whenever there is a distension, signals will be sent to the parasympathetic nervous system that's the time to go and defecate. What is required for the defecation to happen? We will need contractions of the rectum, which might be stimulated by the parasympathetic nervous system. As you can see, the efferent fiber from the lateral horns will come to the wall of the rectum, and the second neuron within the wall, like intramural ganglia. Plus, you should relax the internal sphincter so that it will get open. But these two will not be enough for the defecation to happen. You still have the external sphincter, which is by the skeletal muscles, and it's under voluntary control. And in this case, impulses should come from the brain cortex to the spinal cord, anterior horns, motor neuron, for the external sphincter to get open. So when there will be simultaneous relaxation of external and internal sphincter plus contractions of the rectum, this is when defecation will happen. Now, one more question which you were asking me to review is about intrinsic innervation or enteric nervous system. So, beside parasympathetic and sympathetic nervous system, which is located within the spinal cord, we have intrinsic or enteric nervous system, which is located within the gut. So here I have given you two schemes. As you can see, there is a submucous plexus and myenteric plexus. Submucous, as it comes from the name, it's in the submucous layer, Meissner's one, and also you have myenteric plexus within the muscle layers of the intestine or stomach, for example. So what's the use of intrinsic nervous system or enteric one? It will coordinate the activity or regulation of the sympathetic and parasympathetic. But it also uses local reflexes to operate within the GI tract. It controls most of the functions of the GI tract, especially motility and secretion. And it will do so even in absence of extrinsic innervation, which means for the functions of enteric nervous system, you do not actually need sympathetic or parasympathetic nervous system. It can work by itself. And as you can see, my enteric plexus or Auerbach's plexus primarily controls the motility of the GI tract, which makes sense, it's within the muscle. And submucosal plexus, which is the Meissner's one, it primarily controls the secretion and also the blood flow. And why do we need intrinsic or enteric nervous system? Because as you might remember from anatomy, the length of the intestine is quite long. And imagine if for each and every single step of the digestion, you will be using sympathetic and parasympathetic nervous system, waiting for the impulses to reach the CNS, for the information to be preceded, and then to be sent back for coordination. It will take way too much time. While the enteric nervous system, it's within the wall, like entirely, all of the neurons, afferent and efferent fibers within the wall, which means it will react to any changes quite efficiently. Whenever chyme comes, receptors get stimulated, it will come to the neurons within the wall, and the effectors will be the wall itself. So the reaction will be quite quick, and you don't really need to wait for the digestion to be proceeded. So that's the use of the enteric nervous system. It unloads basically your ANS, gives it a chance to focus on something else, and at the same time, it will provide the regulation within the GI tract. Now, one more question you were asking to review is about the growth hormone influence on the glucose control, but I decided to review a little bit once again the glucose control is. So here you can see the feedback loop. I'm pretty sure you have seen this much, this one or something which looks the same. So we have a homeostasis, which means when the glucose blood level is kept within the normal range. And for example, if glucose level increases, then there will be activation of the beta cells within the pancreas, which will produce the insulin into the blood. When insulin will come into the blood, it will act on target organs and cells, which are most of the body cells, and they will take up the glucose. It will also act on the liver, and liver will convert glucose into the glycogen. And as you know, liver is the depot of glycogen. And these two effects, they will provide the lowering of the glucose level in blood, which means initially high returns back to the normal. And the opposite situation also can happen if, for example, glucose level decreases. For example, you haven't taken a meal in quite some time. In this case, there will be activation of the alpha cells, which release glucagon, which will come into the blood. It will reach the liver, and in liver there will be breakdown of the glycogen into the glucose. So as such, the glucose level is rising, so you're back to normal level. So that's the feedback loop. Both of these are examples of negative feedback, because in one case you increase the glucose level and then you bring it back. In another case, you decrease the glucose level and then you bring it back. So you will manage to maintain homeostasis. And as you might know, you have only insulin to decrease the glucose level, but you have a couple of other hormones which will increase glucose level in blood. Besides glucagon, you also have growth hormone, cortisol, thyroxine, epinephrine. So all of these, they can increase glucose level in blood. So I have taken growth hormone as you requested to discuss how it affects the glucose level, and not only. So as you might remember, growth hormone is produced by anterior pituitary, and it stimulates protein synthesis and overall growth. That's the function which you have learned. And here you have the feedback loop of growth hormone secretion from the hypothalamus. You have liberins and statins for the growth hormone, which will act on anterior pituitary for the growth hormone to be produced, which acts on target organs and tissues. For example, it could be the liver, and somatomedins or insulin-like growth factors will be produced. And if the level of growth hormone becomes too high, then hypothalamic activity will be inhibited, which means there will be no liberins, but there will be inhibiting factor produced, which stops any further secretion of the growth hormone to bring it back to the normal level. And from insulin-like growth factor, you also have the feedback. If the level becomes too high, then it might act on anterior pituitary or hypothalamus to, if it's high, then inhibition of secretion occurs. If it's low, then it will promote secretion of liberins and growth hormone. So that's the feedback itself. Now, what are the possible effects of the growth hormone? As you can see here, we have direct actions and actions of growth hormone through the insulin-like growth factor. Direct actions include decreased glucose uptake into the cells, which means it causes hyperglycemia. Lipolysis, you remember, if we have lipolysis, we can have gluconeogenesis. Increased protein synthesis, and that's the main function of the growth hormone, and production of insulin-like growth factor. So it makes sense because for the protein synthesis, obviously you need lots of glucose. And here you can see the actions of growth hormone indirectly through insulin-like growth factor. Most of them will be based on protein synthesis and action on chondrocytes, muscles, and all of the organs for the growth and development. One more question which you are asking to discuss, effects of transaction of the spinal cord, and one as a separate example is Brown-Séquard syndrome. So what can happen in this case? Obviously, you have to be good in anatomy, so you have to know exactly at which segments, which centers do we have, like which segments, which nerves for which parts of the body are coming. So here you have the overview, but this is like really short summary. There are much more details for all of the segments. So if there will be complete transection of the spinal cord, depends on the level. It could be paraplegia, which means 2 limbs are gone, or quadriplegia, all 4 limbs are gone. Gone means there will be loss of voluntary movements below the level of lesion because you destroy the pathways, the corticospinal tract, which makes you move. It will get destroyed. So the person will no longer be able to voluntarily move. So that's the result of destruction of descending pathways, loss of voluntary movements. The second thing which will happen, loss of conscious sensation, because all of the ascending pathways are also destroyed, which means below the lesion, the person will not be able to feel anything, like no sensation below the lesion. And the final one, the spinal shock. Here you can have 2 stages. Immediately after transection, there will be loss of all the reflexes, and limbs become flaccid and reflexes are absent. But after some time, there will be partial recovery and return of reflexes, and even hyperreflexia, because control of the brain is lost over the spinal cord. So why reflexes will regain? Because as you can see, that's the reason why I have given you the picture. For the reflex to happen, you only need a spinal segment. You do not need the up-above segments. So even if there is a transection above this segment, for example, for the knee jerk, you need L2 to L4. So if transection is above and these segments are not affected, the knee jerk will still remain safe because the fibers, they're safe. So that's the reason why reflexes might return. And here I have given you some of the examples, not all of the lesions at different levels. So like C7, there will be loss of sympathetic regulation of the heart, because you remember that sympathetic control, it's at the 5 upper segments of the thoracic region. So if you cut it at this level, the regulation will be lost. Now, if the lesion is at C3, breathing will stop, because this is where you have the center of the phrenic nerve, which innervates the diaphragm. And if diaphragm will not receive any stimuli from the respiratory center, the person might not be able to breathe. And this is the worst condition, when the entire spinal cord will lose the connection with the upper centers, and it leads to death immediately. And as a separate example, in this case, it's not a complete trisection of the spinal cord, but in this case, it's rather than half of the spinal cord is damaged. It could be transverse hemisection, or it could be compression. Regardless the reason, half of the spinal cord is lost. How to understand which symptoms will develop in this case? For that, you need to revise the conducting pathways, the corticospinal tract and spinothalamic tract, and the level of decussation. Why is it important? Because there will be a difference in the site where the sensation of movements will be lost. So like in this case, you can see this is the half of the spinal cord which is damaged. And on ipsilateral side, you will have spastic paresis, which means loss of motor activity and paralyzed limbs. And on that same side, there will be loss of proprioception and sensation of vibration. But since the decussation of anterior lateral fibers, it happens within the spinal tract, then it will result in contralateral loss of pain and temperature. This is the spinothalamic tract. So there will be sensory dissociation. So as you can see on the diagram, loss of all sensations, loss of temperature, paralysis, and proprioception and vibration, they will happen on different sites because of the decussation, of the level of decussation of the spinal tracts. Now, one more question which you were asking, it's about the compliance of the respiratory system. Compliance, you have the same term applied to the cardiovascular system, and basically describes distensibility of the lungs and chest wall, as you can see on the cartoon animation. So it's inversely related to stiffness or elastic properties of the lung tissue. And it could be described with the help of slope of the pressure volume curve. So basically, it's the change of volume for a given change in pressure. Pressure, in this case, we're talking about the pressure inside the lungs and airways, or it's the transpulmonary pressure. Means the difference between the intra-alveolar pressure and intrapleural pressure. So that's the pressure across the lungs. So why do we need compliance of the lungs? When you have transmural pressure, and when the pressure outside the lungs, which is intrapleural pressure, when it's negative, it helps the lungs to expand. It keeps them inflated, and the lung volume increases. This is when inspiration occurs. But when the pressure outside the lungs is less negative, the lungs will tend to collapse and the volume decreases. So this is how expiration occurs. And within this loop, you can see the inside, this is the middle one, when compliance is the greatest, but at high pressure, compliance becomes the lowest and the lungs the least distensible. That's when the curve flattens. Why do you need to know that? On top, I have given you the picture Like this is the normal compliance. And these are the examples of low compliance and high compliance, which means least distensibility and highest distensibility. These two examples, they can happen in case of diseases. In case of low compliance, you can see they do not resist inflation. And in case of high compliance, they resist being inflated much. Now, one more question about microcirculatory system. So what do we have here? Capillaries. Microcirculatory bed, it's about capillaries. As you know, capillaries, they have the largest surface area, and they consist of a single layer of endothelial cells. It's a pity, but here you're supposed to have the pictures of different types of capillaries. I don't know why it's not visible, but anyway, I'll describe it to you. So capillaries, they have a single layer of endothelial cells surrounded by basal lamina. This is what you have learned in histology. They're very thin walled vessels, and that's the site of exchange of nutrients, water, and gases. According to the functional classification, capillaries belong to exchange vessels. And there are three types of capillaries. Continuous, which is where complete endothelial lining with minute gaps, if any, between the cells. Then you have fenestrated capillaries. They have pores in the plasma membrane of the endothelial cells, which will permit quite nice exchange of water and large substances. These types of capillaries, fenestrated type of capillary, will be present within the kidney. That's the glomerular capillaries, in endocrine glands and in small intestine, so that absorption can happen. And the last one, with the largest gaps, that type of capillary will be present in liver, spleen, bone marrow. So basically these are the organs of hemopoiesis. They have large pores between the endothelial cells so that even the formed elements, they can go through. Sorry, I guess something happened. Now, structure of the capillary bed. As you can see here on the diagram, this is the microcirculatory bed. You have arteriole, which will split into precapillaries with precapillary sphincters. Then you will have capillaries with postcapillaries and the venule. And precapillary sphincters with the arteriole, it will control the amount of blood flowing through capillaries. And clefts, as we have mentioned before, they will allow and they will actually determine the size of a substance which can pass through it. And blood flow, as I said, will be regulated by the contraction or relaxation of the arteriole. Now, why do we need to talk about microcirculatory bed? We need to talk about it regarding the exchange. And there are few types of transport depending on the substance. Like lipid-soluble substance, they can cross membranes quite easily by simple diffusion. And examples of such substances, they include oxygen and CO2. Other small but water-soluble substances, they cross via the clefts, which are water-filled, between the endothelial cells. Examples of such substances include water, glucose, amino acids. And usually protein molecules, as you know, they're quite large to pass freely, so they do not actually leave the bloodstream. And in some organs, because of the barrier, the number of substances which can go through even less than that. Example is blood-brain barrier. But in some organs, as we have mentioned, like sinusoidal type of capillary, they're quite permeable to different substances. if you have a large water-soluble substance, it can cross by pinocytosis. But the main type of exchange is the filtration, which is based on pressure gradients. And in this case, we need to discuss two types of pressures: hydrostatic pressure and oncotic pressure. Hydrostatic pressure, as you can see, this is the force which favors filtration, so it pushes out of the capillary. Oncotic pressure, it opposes the hydrostatic pressure and it opposes filtration. As you can see here, there is a minus. Plus stands for favoring. And by the size of these arrows, you can see these two are the most influential ones because their values will be the greatest. This is the hydrostatic pressure of the capillary and oncotic capillary pressure. But since it's the exchange between the capillary and the interstitial fluid, we also have hydrostatic pressure of the interstitial fluid and oncotic pressure of the interstitial fluid. Hydrostatic interstitial, it opposes filtration, minus. But the value is very little, that's why it's so thin. Oncotic interstitial pressure, it favors filtration, plus, but the value is really very small. And if you need to consider all these four forces, you can make an equation. This is the net filtration of fluid movement, this is the coefficient, and you can look at it as the difference between hydrostatic pressures, like hydrostatic capillary, hydrostatic interstitial, because they are in opposite directions. That's why the difference. Minus the difference of oncotic pressures for the same reason. One is opposing, one is favoring. That's why it's minus. And if you will try to count the difference, in the end, you will see that this force is still favoring and this force is still opposing. That's the reason why here you also have minus. Now let's take a look at the values. So as you know, in the capillaries we have arterial and venous end. At the arterial end, hydrostatic pressure will be around 35. At the venous end, hydrostatic pressure will be around 16. The rest of the pressures, they will not differ throughout the capillary. Blood oncotic pressure remains 26 all over the capillary. Interstitial pressure, in this case, you can see it's given as 0. And interstitial oncotic pressure is 1. So you can see the values are like very small. And if you will try to put these values into the formula, here you can see the formula is a little bit different. Why is different? Because instead of subtracting, they're adding. So in first brackets, they're using all the pressures which promote filtration. In our case, it will be blood hydrostatic pressure, as you remember, it promotes filtration, and oncotic pressure of interstitial fluid. Hydrostatic capillary plus oncotic. So that's why we can use a summary of these two. And in second bracket, you will have pressures promoting reabsorption, which means opposing filtration. And it will be oncotic capillary pressure and hydrostatic interstitial pressure. So after calculations, you will see that at the arterial end, if you're going to use 35, the final value will be plus 10, which means the force which promotes filtration is greater than the one opposing, which will determine the filtration at the arterial end. But at the venous end, if you will take 16 instead of 35, you will see that the final value will be minus 9, which means net reabsorption will occur. So this is when the fluid returns back. And usually the filtration of fluid out of the capillary is slightly more than the reabsorption of fluid into the capillary. And excess of the fluid will go to the lymphatic system, and furthermore, it will be returned back into cardiovascular system. So this is basically how formation of lymph happens within the capillaries. And one more question which I was asking, which you were asking to review, hormonal response to stress. Stress usually is described within a general adaptation syndrome, which was discovered by and described by Hans Selye. General adaptation syndrome, this is non-specific response of the body towards the stressful event. And how he described the stress, he described it through 3 stages. Here you can see the graph. The graph is actually pretty simple. You have ascending part, then you have kind of a plateau, and then you have descending part. So what do we have here? The first phase is alarm stage. This is when resistance drops at first, as the sympathetic nervous system gets quickly activated. As you understand, alarm, this is something urgent, when you have to quickly react towards the stimulus. But resistance then rapidly increases as the body will mobilize its defense system. And in resistance stage, which is actually the plateau, the body is working at these conditions with increased level of resistance, using resources until the stress will end or get resolved, or maybe the body will run out of resources. And if the body runs out of the resources, exhaustion might occur. And in exhaustion stage, the body is no longer able to resist the stress, as all of the resources they are depleted. And at this point, disease or even death might occur. So basically, as you can see here, why I was using this graph. Resistance stage, that's your comfort zone, when your performance is optimal. But any deviation might lead to distress and exhaustion. It leads to burnout or various disorders. So let's take a look at the stages. Alarm phase. This is when the body first reacts to the stressor. The sympathetic nervous system is activated. The adrenal gland releases hormones that will increase the heart rate, the blood pressure, the supply of blood to organs. The glucose level will rise, which gives you the burst of energy. Now, the next one, but as you understand, the body cannot live in such a stage for a long time. Luckily, we have resistance stage. As the stress continues, the body settles into sympathetic division activity, continue to release the stress hormones, which help the body to fight off or resist the stressor. And in this case, if the stressor will continue, we will use our resources. But if the stressor will be way too long lasting, depletion might eventually occur, which leads to exhaustion. When the body resources are gone, completely, that's what is known as exhaustion. And it might lead to formation of stress-related diseases like hypertension, weakening of your immune system, or even death of the organism if there will be no help provided. And when the stressor will end, the parasympathetic division will get activated, trying to replenish the resources. As you remember, parasympathetic is used for rest and digest. So, alarm and resistance are the stages that we are experiencing many times throughout the lifetime, and it allows us to adapt to life's demand. And if there will be prolonged secretion of all the stress hormones during the exhaustion state, it might lead to harmful effects of stress, leading to diseases. But if you will manage to remain within the comfort zone, and if the stress is not too long lasting, adaptation will happen. That's the optimal activity or this is what is called as eustress or positive stress, when you manage to adapt to the stressful situation. So let's take a look at the hormones there are two most important groups of hormones. One group, it will provide short-lasting effects. And as you understand, these are the catecholamines, epinephrine and norepinephrine. And here on this slide, you can see a summary of main effects of these two hormones. And as you can see, these hormones, they increase glucose level by stimulating the liver and muscles to break down the glycogen and convert it into the glucose, increasing the available glucose level in blood. Besides that, these hormones will increase oxygen availability. How will it happen? You will have increased heart rate, you will have a bronchodilation, which will provide more oxygen available. And these hormones also prioritize the body functions by redistributing the blood supply to essential organs such as heart, brain, skeletal muscles, lungs, and at the same time restricting blood flow to organs not immediately needed, such as skin, GI tract, kidney. So this is what is known as redistribution of the blood flow. And in some organs you will have vasoconstriction, but while in important organs like the heart, you will have vasodilation. So these are the short-term stress responses. This is what happens during alarm stage. During resistance stage, you will have long-term stress responses. And examples of hormones which will be involved into this stage will be cortisol, thyroid hormones like T3, T4, growth hormone, insulin, because energy is still needed to fight with the stress. And the most important hormone within this stage is the cortisol. As you might have heard, this is also known as stress hormone. So here you can see the feedback of its secretion, like stress, which might lead to the production of CRH, which is corticotropin-releasing hormone, by the hypothalamus, which will enter the anterior pituitary and will stimulate production of ACTH, adrenocorticotropic hormone, which will further act on the cortex of the suprarenal gland for the production of the cortisol. And here you can see some of the effects of the cortisol, desirable effects which will help you to combat with the stress. So as you understand, once again, the body cannot sustain the burst of energy mediated by epinephrine and norepinephrine for a long time. Instead, other hormones will come into play. In a long stress response, the hypothalamus will trigger the release of ACTH from anterior pituitary. And in response, the adrenal cortex stimulated by ACTH will release steroid hormones called corticosteroids or glucocorticoids. An example is the cortisol. And the effects of cortisol will be, they target cells for the breakdown of fat into the fatty acids in the adipose tissues. And these fatty acids are released into the bloodstream for other tissues to use it for the ATP production, like gluconeogenesis. So that's the lipolysis, to increase the energy available. Glucocorticoids also, that's the way why they are called glucocorticoids. They primarily affect glucose metabolism by stimulating glucose synthesis. So there will be increased energy available. So they increase glucose synthesis, and few more important effects which they have is anti-inflammatory effect and anti-allergic, because they suppress, they are immune suppressing. So glucocorticoids and cortisol, that's the most important hormone in long-term stress response. So that's all as for the material which I would like to present to you today. Thank you for your attention and have a nice day.